Welcome to another deep dive. Today we're dissecting something incredibly intricate, pelvic vascular control. It's a field where precision isn't just, nice to have. It's absolutely fundamental. Life or death, really. Imagine trying to navigate this incredibly dense, vital network inside the body. One slip. Serious immediate trouble.
Absolutely. The stakes are incredibly high.
So our mission here is to pull out the key insights, the real gems from our source material, pelvic vascular control, surgical dicta, and dissection techniques. And these aren't just, dry anatomical facts you memorize for a test.
No, not at all. This is accumulated wisdom, hard-won knowledge from the operating room itself. These are the protocols that actually guide surgeons.
Exactly. Protocols, or dicta, as they call them.
Right, dicta. These often unwritten rules, these critical techniques that, well, they literally guide a surgeon's hands during these incredibly delicate procedures. What's really fascinating, I think, is how tiny anatomical details, things you might overlook, translate directly into life-saving actions. It's not just knowing what's there, which artery, which nerve, but understanding how to interact with it safely, strategically, especially under pressure.
So if you've ever been curious about just how precise surgery needs to be, or maybe how professionals get so good at managing these complex, high-risk situations, well, you're in the right place. Let's unpack this. Let's find that hidden wisdom in these surgical guidelines.
Sounds good. Where should we start?
Okay, let's dive straight into some of these crucial surgical dicta, the kind of golden rules, the absolute must-knows for navigating the pelvis safely. Maybe we can start with a big one, an artery that's often central in emergencies. The internal iliac artery.
Yes. A critical player. Its role in managing severe pelvic hemorrhage is, well, paramount. We're talking about situations like major trauma or complications during childbirth, where bleeding can become catastrophic very quickly. This artery is often the primary target for control.
So how do they control it? There's a specific rule, a dictum for ligating it, right, for tying it off.
Exactly, ligation. And the dictum is very precise about the location. It has to be just distal to where the artery splits the bifurcation but before its main branches take off. And there's a very good reason for that specific spot.
Why there specifically? What happens if you go too high, too proximal?
Well, if you ligate proximal to those crucial branches, you risk cutting off blood supply to really important areas downstream. Think gluteal muscles, the perineum. You could cause ischemia, tissue death. So it's this fine balance. Stop the hemorrhage, yes, but don't create a whole new crisis. It's like threading a needle.
Wow. Okay. And there's a physical technique involved, too. You mentioned identifying the ureter.
Right. That's the key maneuver.
Yeah.
You have to positively identify the ureter, that tube carrying urine, and gently, carefully push it medially. Move it out of the danger zone. Then you use a special tool, a right-angle instrument, to carefully pass around the artery itself before tying it off. It's all about clear visualization and careful manipulation.
And the dictum also mentioned something specific. Posterior division must be preserved for gluteal perfusion. Why highlight that posterior part?
That's a critical point. That posterior division supplies the gluteal muscles, among other things. Preserving it is vital for maintaining function walking, stability. If you accidentally tied off that division while trying to stop the main bleed, well, you might solve the immediate hemorrhage, but you could leave the patient with permanent muscle damage, necrosis even.
So it's about thinking ahead, solving the immediate problem without causing a long-term debilitating one.
Precisely. It's surgical foresight, always considering the downstream consequences of every single move.
Okay, that makes sense for those really deep, major vessels. Let's shift gears a bit. What about an artery many might have heard of, especially regarding women's health, the uterine artery? What's notable about its anatomy?
The uterine artery, yes. What's really interesting there is its relationship with its neighbor, the ureter.
Right, it crosses over, doesn't it? That famous mnemonic.
Water under the bridge, exactly.
Mm-hmm.
The ureter carrying the water runs underneath the uterine artery, the bridge. It's a classic anatomical relationship. And this is critical during procedures like hysterectomy, removing the uterus.
So how do you handle that crossing safely? You need to clamp the artery without hurting the ureter?
The dictum here involves a specific maneuver. You skeletonize the uterus, basically, carefully dissect away the surrounding tissue, and then you pull the uterus medially. This action puts the uterine artery on stretch, lifts it slightly, and clearly reveals the ureter running underneath it. Then you can safely clamp and ligate the artery without putting the ureter at risk. It's really quite an elegant solution to a very common anatomical challenge. Protects the urinary system while controlling blood flow.
That is elegant, but anatomy isn't always so predictable, is it? Let's talk about something that sounds, well, a bit more alarming. The obturator artery and this thing called corona mortis.
Ah, the corona mortis. Yes, that name does sound ominous. Literally crown of death.
What exactly is it? Why the dramatic name?
Well, it comes down to anatomical variation. Usually the obturator artery branches off the internal iliac artery, as you'd expect. But sometimes, and this is the key, it can arise from the external iliac artery instead, or even from the inferior epigastric artery. When it takes one of these unusual paths, especially if it runs close to or directly over the superior pubic ramus, part of the pelvic bone, that variant vessel is called the corona mortis,
And why is that variation so dangerous?
because it puts a significant artery in an unexpected place, right where surgeons might be working during common procedures. Think hernia repairs or dealing with pelvic fractures, especially anterior ones. An instrument or even a surgical tack or screw could easily puncture this aberrant vessel if the surgeon isn't aware of the potential variation. And because it can be a direct branch off a major artery like the external iliac, the bleeding can be, well, catastrophic.
How common is this variation, though? Is it something surgeons rarely encounter?
Actually, it's more common than you might think. Estimates vary, but some studies suggest it could be present in, say, 10%, maybe up to 30% of individuals in some form. So the real-world implication is that surgeons must anticipate it. Even in a routine hernia repair, you can't just assume the anatomy is textbook. Anatomy always keeps you on your toes.
Okay, so with potentially lethal variation being relatively common, what's the rule? What's the dictum to avoid disaster?
The dictum is absolutely clear. Always sweep the pubic ramus with a blunt dissector before cutting any vessel-like structure. It's not optional. It's a proactive safety check. You use a blunt instrument to gently feel along the bone, sweeping the area to detect any unexpected vessels before you make a cut or place a clamp. It forces you to confirm the anatomy tactically, not just visually. It respects that potential for variation.
A simple sweep to potentially avoid a crown of death. Makes sense. Let's cover one more rule of the road, the internal pudendal artery. You mentioned it has a peculiar path.
Oh, it really does. Its journey is quite remarkable, almost acrobatic. It leaves the main pelvic cavity through the greater sciatic foramen.
Okay.
Then it loops, makes this dramatic U-turn around a key structure called the sacrospinous ligament, and then it actually re-enters the pelvis through the lesser sciatic foramen to supply the perineum.
Wow, it exits and then comes back in.
Exactly. This winding, somewhat hidden path makes it vulnerable during certain surgeries. Things like perineal procedures or sacrospinous fixation for pelvic organ prolapse. Because it makes that sharp turn, it's easy to injure if you're not specifically thinking about its course.
So what's the memory aid, the dictum for this one?
It's beautifully simple. Know the arc of pudendal, it's U-shaped. It gives surgeons a clear mental image, a visual reminder of that characteristic curve, so they can anticipate its location and steer clear. Reduces the risk significantly.
So these dictums are like critical navigation rules, but knowing the rules is one thing. How do surgeons actually do it? How do they achieve that precision deep inside the pelvis? They don't have X-ray vision.
Right, that's the bridge from knowledge to action.
Yeah.
It comes down to very specific, learned dissection techniques, often called push-pull reveals. These are deliberate maneuvers, sometimes quite subtle, designed to physically expose and isolate the structures they need to see or work on.
Can you give an example, like for that internal iliac ligation we discussed?
Sure. For the internal iliac, one key maneuver is to push the ureter medially. Gently move it aside to clear the view and protect it. Or, remember the uterine artery and the ureter, the water under the bridge?
Yeah.
The maneuver there is to lift the uterus, the top part, the fundus. That tension nicely exposes both the artery and the ureter beneath it, making that relationship clear and allowing safe clamping.
So it's not just passive observation, it's active manipulation of the tissues to create the view you need, like setting up the surgical field strategically.
Precisely. You're creating safe corridors, improving visibility. It's very active.
What about other vessels, maybe smaller ones, like the middle rectal artery? Are there specific techniques there too?
Indeed. The middle rectal artery. It's often described as small or variable, but it can be really important. The reason is that in anastomosis, it connects quite freely with the superior and inferior rectal arteries. It forms part of this rich network of blood supply to the rectum.
So an injury there isn't necessarily isolated?
Exactly. Damaging it can lead to bleeding that's harder to pinpoint because the blood supply network can compensate or bleed from multiple points. It's like a leak in interconnected plumbing. Tricky to find the source sometimes. So during procedures like a low anterior resection, removing part of the rectum, there's a specific tip. Ensure really good hemostasis, stop all bleeding, particularly near the mesorectum, that fatty tissue around the rectum. Often, this involves careful use of bipolar cautery near the lateral stalks of the rectum. It just shows that even vessels considered minor need meticulous attention to prevent complications.
And these push-pull techniques, these active maneuvers, they apply broadly, right? It's a whole philosophy.
Absolutely. It's a consistent approach. You might push the rectum posteriorly to get a better look at its branches, or you might sweep the pelvic side wall laterally. Again, to clearly identify things like the obturator artery and nerve, keeping them safe. It's all about creating that safe, visible working space within a very complex three-dimensional environment.
Is there one technique you'd highlight as particularly clever or effective for gaining access?
Well, one that's really quite brilliant, mentioned in the source material, is dissecting under the peritoneal reflection. That's the lining of the abdominal cavity, which folds over the pelvic organs. If you go underneath that fold, specifically in spaces like the perirectal space beside the rectum or perivesical space beside the bladder,
Okay. What's the advantage there?
the advantage is a vascular access. These planes, these spaces under the peritoneum, often have very few blood vessels. So, by choosing that route, surgeons find a path of least resistance, minimizing bleeding, which dramatically improves visibility and safety when accessing deeper structures like the internal iliac system. It's these kinds of smart, experience-based insights finding the easy way in, that's also the safest way, that really show the depth of surgical craft, passed down, refined over years.
That's fascinating, choosing the path with fewer obstacles, fewer risks.
Exactly. It's strategic. And when you think about it, these dicta and these techniques, they're not just rules written down. They are the concentrated essence of countless hours of experience, of managing complexity, of minimizing risk. They really embody deep critical thinking about the anatomy, about its variations, and about the choreography needed for safe surgery. It goes way beyond just knowing where things are. It's knowing how they behave, how they might surprise you, and how to interact with them expertly.
Right. So today, we've really taken a deep dive, haven't we, into this almost hidden world of pelvic vascular control. We've seen the incredible precision required, learned about these crucial dicta, the guiding principles, and explored some of those clever push-pull maneuvers that make safe surgery possible. It really highlights how deep anatomical knowledge, combined with meticulous, sometimes quite subtle physical technique, becomes, well, almost an art form, a dance of precision inside the human body.
It truly is.
So what's the takeaway for you listening? Maybe it's just a deeper appreciation for the incredibly detailed mental maps that experts, like surgeons, carry in their heads, maps that guide their hands through some of the most complex landscapes imaginable. Think about all those unseen details just beneath the surface, in any complex field, really, and how knowing them, anticipating them, having protocols for them can fundamentally change an outcome. It kind of leaves you wondering, doesn't it, about all the other silent critical protocols, the unwritten dicta that guide experts everywhere, far beyond the operating room. What hidden knowledge, what seemingly small details hold the keys to success in other demanding professions? Makes you think.